This video lecture was made by the Center for Future Dentistry under the SNUSD Knowledge Share Initiative with the support of the Korean Ministry of Trade, Industry, and Energy. Welcome to Virtual Anatomy, the Vanatomy class. This lecture is the 18th lecture of the Vanatomy series. I'm Dr. Stratich. Following the past two sessions, the final part, that is the part 3, will summarize the rest of head and neck muscles that you need to know to understand head and neck anatomy properly. The first one is the muscles of the palate. We have 5 soft palate muscles. Levatory Palatini. This muscle is the elevator muscle of the soft palate. During swallowing, it contracts, elevating the soft palate to help prevent food from entering the nasopharynx. It is innervated by a pharyngeal plexus, more specifically the pharyngeal branch of the vagus nerve. The Levatory Palatini is a thick and rounded muscle situated lateral to the choana, that is the posterior nasal aperture. It arises from the undersurface or inferior surface of the apex of the petrous part of the temporal bone and from the medial lamina of the cartilage of the auditory tube. After passing above the upper concave margin of the superior pharyngeal constrictor, it is spread out in the palatine velum, its fibers extending obliquely downward and medially to the midline, whereby they blend with those of the opposite side. So, the insertion of this muscle can be described as a palatine aponeurosis. The arterial supply of this muscle is from the ascending palatine artery or facial artery. Transverse Palatini muscle. This muscle can be called as a tens palati or tens muscle of the velum palatinum. It is broad, thin, and ribbon-like muscle in the head that tenses the soft palate. This muscle is found anterior and lateral to the Levatory Palatini muscle. It arises by a flat lamella from the scaphoid fossa at the base of the medial pterygoid plate, from the spina angularis of the sphenoid, and from the lateral wall of the cartilage of the auditory tube. Descending vertically between the medial pterygoid plate and the medial pterygoid muscles, it ends in a tendon which winds around the pterygoid hamulus, being retained in the situation by some of the fibers of origin of medial pterygoid muscle. Between the tendon and the hamulus is a small bursa. The tendon then passes medially and is inserted in the palatine aponeurosis and into the surface behind the transverse ridge on the horizontal part of the palatine bone. The Transverse Palatini is supplied by the medial pterygoid nerve, a branch of mandibular nerve, the third branch of trigeminal nerve, the only muscle of the palate not innervated by the pharyngeal plexus, which is formed by the vagal and the glossopharyngeal nerve. The Transverse Palatini tenses the soft palate and by doing so assists the Levatory Palatini in elevating the palate to occlude and prevent entry of food into the nasopharynx during swallowing. The tensed palate consequently provides a stable platform for elevation of the pharynx during swallowing by the pharyngeal muscles. Since it is also attached to the lateral cartilaginous lamina of the auditory tube, also known as the Eustachian tube, it assists in its opening during swallowing and yawning to allow air pressure to equalize between the tympanic cavity and the outside of the air. Equalization of air pressure in tympanic cavity is essential for preventing damage to the tympanic membrane and a resulting loss of hearing acuity. Its innervation can be described more specifically as the medial pterygoid or mandibular nerve. Ovular muscle. It changes the contour of the posterior part of the soft palate. This change in contour allows the soft palate to adapt closely to the posterior pharyngeal wall to help close the nasopharynx during swallowing. These muscles are controlled by the pharyngeal branch of the vagus nerve. It originates from the posterior border of the hard palate and the posterior nasal spine of the horizontal plate of the palatine bone. It inserts to the palatine aponeurosis and mucosa of the uvula. Its main action is to move and change the shape of the uvula. Palatoglossal muscle. It is also called as the palatoglossal muscle. It is a small flesh vesiculus narrower in the middle than at either end, forming with the mucous membrane covering its surface the glossopalatine arch. Palatoglossus arises from the palatine aponeurosis of the soft palate, where it is continuous with the muscle of the opposite side and passing downward, forward, and lateralward in front of the palatine tonsil, is inserted into the side of the tongue, with some of its fibers spreading over the dorsum and others passing deeply into the substance of the organ to intermingle with the transverse muscle of the tongue. Palatoglossus can be classified as the extrinsic tongue muscles also, and is not innervated by the hypoglossal nerve peculiarly. However, when it is classified as the soft palate muscles, it is natural to be innervated by the pharyngeal branch of the vagus nerve. It elevates posterior tongue, closes the oropharyngeal isthmus, and aids initiation of swallowing. This muscle also prevents the spill of the saliva from the vestibule into the oropharynx by maintaining the palatoglossal arch. And it also aids in breathing by raising back part of the tongue. Palatopharyngeus muscle. It is also called as a palatopharyngeal or pharyngopalatinous muscle. It is a small muscle in the roof of the mouth. It is a long flesh fasciculus narrower in the middle than at either end, forming with the mucosa membrane covering its surface the palatopharyngeal arch. It is separated from the palatoglossal muscle by an angular interval in which the palatine tonsil is lodged. It arises from the soft palate, where it is divided into two fasciculus by the Levatory Palatini and the ovular muscles. The posterior fasciculus lies in contact with the mucous membrane and joins with that of opposite muscle in the midline. The anterior fasciculus, the thicker, lies in the soft palate between the levator and Transverse Palatini muscles and joins in the middle line the corresponding part of the opposite muscle. Passing laterally and downward behind the palatine tonsil, the palatopharyngeus joins the stylopharyngeus and is inserted with that muscle into the posterior border of the thyroid cartilage, some of its fibers being lost on the side of the pharynx and others passing across the midline posteriorly to decussate with the muscles of the opposite side. So overall, its origin can be described as the posterior border of hard palate and palatine aponeurosis, and its insertion can be described as the posterior border of the thyroid cartilage, and it blends with contralateral palatopharyngeus muscle. Motor innervation of this muscle is provided through an pharyngeal plexus of the vagus nerve. The palatine velum is slightly raised by the Levatory Palatini and made tense by the Transverse Palatini. The palatopharyngeus muscle, by their contraction, pull the pharynx upward over the bolus of food and nearly come together, the uvula filling up the slight interval between them. By this means, the bolus is prevented from passing into the nasopharynx. At the same time, the palatopharyngeus muscle form an inclined plane directed obliquely downward and backward along the undersurface of which the bolus descends into the lower part of the pharynx. It is supplied by the facial artery branch. Moving on to the muscles of tongue. First, we will talk about the extrinsic muscles of tongue. Genioglossus. The genioglossus is one of the paired extrinsic muscles of tongue. It is the major muscle responsible for protruding or sticking out the tongue. Genioglossus is a fan-shaped extrinsic tongue muscle that forms the majority of the body of the tongue. It arises from the mental spine of the mandible, and its insertion are the hyoid bone and the bottom of the tongue. The genioglossus is innervated by the hypoglossal nerve, as are all muscles of the tongue except the palatoglossus. Blood is supplied to the sublingual branch of the lingual artery, a branch of the external carotid artery. The left and right genioglossus muscles protrude the tongue and deviate it towards the opposite side. When acting together, the muscles depress the center of the tongue at its back. Hyoglossus muscle. It is a thin and quadrilateral muscles and arises from the side of the body and from the whole length of the greater cornu of the hyoid bone. And it passes almost vertically upward to enter the side of the tongue, between the styloglossus and the inferior longitudinal muscles of the tongue. It forms a part of the floor of the submandibular triangle. The lingual vein passes medial to the hyoglossus, and the lingual artery passes deep to the hyoglossus. Laterally, in between the hyoglossus muscle and the mylohyoid muscle, lay several important structures from upper to lower sublingual gland, submandibular duct, and lingual nerve. Vena comitans of hypoglossal nerve and hypoglossal nerve. Notably, to the posterior, the lingual nerve is superior to the submandibular duct, and a portion of submandibular salivary gland protrudes into the space between the hyoglossus and the mylohyoid muscle. The hyoglossus depresses and retracts the tongue and makes the dorsum more convex. Styloglossus muscle. This is the shortest and smallest of the three styloid muscles, arises from the anterior and lateral surface of the styloid process near its apex, and from the stylomandibular ligament. Passing inferiorly and anteriorly between the internal and external carotid arteries, it divides upon the side of the tongue near its dorsal surface, blending with the fibers of the inferior longitudinal muscles of tongue in front of hyoglossus muscle. The other, oblique, overlaps the hyoglossus and decussate with its fibers. The styloglossus is innervated by the hypoglossal nerve, like all muscles of the tongue except the palatoglossus. The styloglossus throw up the side of the tongue to create a trough for swallowing. As a pair, they also aid in retracting the tongue. Its antagonist is the inferior and middle fibers of the genioglossus, and it is supplied by the sublingual branch of the lingual artery. Finally, we have palatoglossal muscle additionally as a extrinsic muscles of tongue. The next is the extrinsic muscles of tongue. However, unfortunately, the Anatomage table do not have these muscles distinctively. So, I will give you the brief explanation of the intrinsic muscles of tongue instead. We have 4 intrinsic muscles of tongue, like extrinsic muscles of tongue. That is, superior longitudinal and inferior longitudinal, and transverse and verticalis. Superior longitudinal muscles originate from close to the epiglottis from median fibrous septums and inserts to the edge of the tongue. And the inferior longitudinal muscles originate from the root of tongue and inserts to the apex of the tongue. The transverse muscle of the tongue originates from the median fibrous septum and inserts to the side of the tongue. The vertical muscle or verticalis originates from the dorsum of the tongue and inserts to the inferior surface borders of the tongue. These 4 muscles have innervation from the hypoglossal nerve. Superior longitudinal muscles shortens tongue's tip upward, tongue's lateral margins upward. Inferior longitudinal muscles shortens the tongue, retracts, pulls tip downward. Transverse muscles of tongue narrows and not elongated. Okay, now let's move on to the muscles of pharynx. First, the constrictor muscles of pharynx will be discussed. Superior pharyngeal constrictor muscle. It is the highest located muscles of the 3 pharyngeal constrictors. This muscle is a quadrilateral muscle thinner and paler than the inferior or middle pharyngeal constrictor muscle. The muscle is divided into 4 parts: a pterygopharyngeal, buccopharyngeal, myelopharyngeal, and a glossopharyngeal part. The 4 parts of this muscle arises from as follows. The pterygopharyngeal part arises from the lower third of the posterior margin of the medial pterygoid plate and its hamillus. The buccopharyngeal part arises from the pterygomandibular raphe. The myelopharyngeal part arises from the alveolar process of the mandible above the posterior end of the mylohyoid line. The glossopharyngeal part arises by a few fibers from the side of the tongue. The fibers curve backward to be inserted into median raphe, being also prolonged by means of the aponeurosis to the pharyngeal spine or tubercle on the basilar part of the occipital bone. The superior fibers arch beneath the Levatory Palatini and the Eustachian tube. The interval between the upper border of the muscle and the base of the skull is closed by the pharyngeal aponeurosis and is known as the sinus of the Morgagni. There is an interval between superior pharyngeal constrictor and middle pharyngeal constrictor, and this space contains the glossopharyngeal nerve and the styloglossus muscle. As soon as the bolus of food is received in pharynx, the elevator muscle relaxes, the pharynx descends, and the constrictor contracts upon the bolus and convey it downward into esophagus. The superior pharyngeal constrictor muscle is innervated by the pharyngeal branch of the vagus nerve by a pharyngeal plexus. It is supplied by ascending pharyngeal artery and the tonsillar branch of the facial artery. Its main action is swallowing. Middle pharyngeal constrictor muscle. It is a fan-shaped muscle located in the neck. It is one of the three pharyngeal constrictors. Similarly to the superior and inferior pharyngeal constrictor, the middle pharyngeal constrictor is innervated by a branch of the vagus nerve through a pharyngeal plexus. The middle pharyngeal constrictor is smaller than the inferior pharyngeal constrictor. This muscle arises from the whole length of the upper border of the greater conus of the hyoid bone, from the lesser conus, and from the stylohyoid ligament. The fibers diverge from their origin. The lower ones descend beneath the constrictor inferior, the middle fibers pass transversely, and the upper fibers ascend and overlap the constrictor superior. It is inserted into the posterior median fibrous raphe, blending in the middle line with the muscles of the opposite side. It is supplied by the ascending pharyngeal artery, and it is innervated by the pharyngeal plexus of the vagus nerve, as I said. As soon as the bolus of food is received in the pharynx, the elevator muscles relax and pharynx descends, and the constrictor contracts upon the bolus and convey it downward into the esophagus. It is same as the superior constrictor pharyngeus muscles. And the middle pharyngeal constrictor muscles have respiratory mechanical effect. Inferior pharyngeal constrictor muscle. It is the thickest of the three constrictors, arises from the side of the cricoid and thyroid cartilage. Similarly to the superior and middle pharyngeal constrictor muscles, it is innervated by the vagus nerve, specifically by branches from the pharyngeal plexus and by neuronal branches from the recurrent laryngeal nerve. The muscle is composed of two parts, the first arising from the thyroid cartilage, so it is called as a thyropharyngeal part, and the second arises from the cricoid cartilage, so it is called as a cricopharyngeal part. The thyropharyngeal part arises from the oblique line on the side of the lamina, from the surface behind this nearly as far as the posterior border, and from the inferior conus. Cricopharyngeal part arises in the interval between the cricothyroid in front and articular facet for the inferior conus of the thyroid cartilage behind. From these origins, the fibers spread backward and medialward to be inserted with the muscles of opposite side into the fibrous pharyngeal raphe in the posterior median line of the pharynx. The inferior fibers are horizontal and continuous with the circular fibers of the esophagus. The rest ascends, increasing in obliquity, and overlap the constrictor medius. The cricopharyngeal muscle is synonymous with the upper esophageal sphincter, which controls the opening of cervical esophagus, and is sometimes referred to as the cricopharyngeal inlet. As soon as the bolus of food is received in the pharynx, the elevator muscles relax, the pharynx descends, and the constrictor contracts upon the bolus and convey it downward into the esophagus. It is same as with the other constrictor pharyngeus muscles. During deglutition, the inferior pharyngeal constrictor muscle contracts and causes peristaltic movement in the pharynx. The next is elevator muscles of pharynx. We have three elevator muscles of pharynx. One of them, palatopharyngeus, was already discussed in the section of Muscles of palate. Stylopharyngeus muscle. It is a muscle in the head that stretches between the temporal styloid process and the pharynx. It is a long, slender muscle, cylindrical above, flattened below. It arises from the medial side of the base of the temporal styloid process, passes downward along the side of the pharynx between the superior pharyngeal constrictor and the middle pharyngeal constrictor, and spreads out beneath the mucous membrane. Some of its fibers are lost in the constrictor muscles, while others, joining the palatopharyngeus muscle, are inserted into the posterior border of the thyroid cartilage. The glossopharyngeal nerve runs on the lateral side of this muscle and crosses over it to reach the tongue. The stylopharyngeus is the only muscle in the pharynx innervated by the glossopharyngeal nerve via branchial motor neurons, with their cell bodies in the rostral part of the nucleus ambiguous. Embryological origin is the third pharyngeal arch. The stylopharyngeus elevates the larynx and pharynx and dilates the pharynx to permit the passage of a large food bolus, thereby facilitating swallowing. It is supplied by the pharyngeal branches of the ascending pharyngeal artery. Salpingopharyngeus muscle. It arises from the cartilage around the eustachian tube and inserts into the palatopharyngeus muscle by blending with its posterior fasciculus. It raises the pharynx and larynx during swallowing and laterally draws the pharyngeal walls up. It opens the pharyngeal orifice of the eustachian tube during swallowing, allowing the equalization of pressure between it and the pharynx. The salpingopharyngeus is supplied by the vagus nerve via pharyngeal plexus and is supplied by the ascending pharyngeal artery. The palatopharyngeus muscle is already discussed in other sections, as I said. The next is the extraocular muscles. Superior rectus muscle. It is innervated by the superior division of the oculomotor nerve. In the primary position, as known as the looking straight ahead, its primary function is elevation, although it also contributes to intorsion and adduction. It is associated with a number of medical conditions and may be weak, paralyzed, overreactive, or even congenitally absent in some people. The superior rectus muscle originates from the annulus of Zinn. It inserts into the anterosuperior surface of the eye. This insertion has a width around 11 mm, and it is around 8 mm from the corneal limbus. The superior rectus muscle elevates, adducts, and helps intort, that is to say, rotate medially, the eye. Medial rectus muscle. It originates from the annulus of Zinn and inserts into the anteromedial surface of the eye. It is supplied by the inferior division of the oculomotor nerve. It rotates the eye medially, so to speak, adduction. Lateral rectus muscle. This muscle is responsible for lateral movement of the eyeball, specifically abduction. Abduction describes the movement of the eye away from the midline, that is to say, nose, allowing the eyeball to move horizontally in the lateral direction, bringing the pupil away from the midline of the body. The lateral rectus is the only muscle supplied by the abducens nerve. The neuron cell bodies are located in the abducens nucleus in the pons. These neurons project axons as the abducens nerve, which exits from the post-medullary junction of the brainstem travels through the cavernous sinus and enters the orbit through the superior orbital fissure. It then enters the medial surface of the lateral rectus to innervate it. The lateral rectus muscle originates at the lateral part of the annulus of Zinn, as known as the annular tendon or common tendinous ring. The annulus of Zinn is a tendinous ring that surrounds the optic nerve and serves as the origin for 5 of the 6 extraocular muscles excluding the inferior oblique muscles. The lateral rectus muscle inserts to the temporal side of the eyeball. Its insertion is around 7 mm from the corneal limbus. It has width of 10 mm. Inferior rectus muscle. This muscle originates from the annulus of Zinn and inserts into the anteroinferior surface of the eye. It depresses the eye downward. The inferior rectus muscle is supplied by the inferior muscular branch of the ophthalmic eye. It may also be supplied by a branch of the infraorbital artery. It is drained by the corresponding veins, the inferior muscular branch of the ophthalmic vein and sometimes a branch of the infraorbital vein. The inferior rectus muscle is supplied by the inferior division of the ocular motor nerve. The insertion of this muscle has a width of around 10.5 mm. It is around 7 mm from the corneal limbus. Its main action is to depress the eyeball and adduction of eyeball, and helps to extort the eye. It is the only muscle that is capable of depressing the pupils when it is in a fully abducted position. Superior oblique muscle. It is also called as obliquus oculi superior. It is a fusiform muscle originating in the upper medial side of the orbit, which abducts, depresses, and internally rotates the eye. It is the only extraocular muscle innervated by the trochlear nerve. The superior oblique muscle loops through a pulley-like structure, or trochlea of the superior oblique muscle, and inserts into the sclera on the posterior temporal surface of the eyeball. It is the pulley system that gives the superior oblique its action, causing depression of eyeball despite being inserted on the superior surface. The superior oblique arises immediately above the margin of the optic foramen, superior and medial to the origin of the superior rectus, and passing forward ends in a rounded tendon which plays in a fibrocartilaginous ring or pulley attached to the trochlear fossa of the frontal bone. The continuous surface of the tendons and rings are lined by a delicate mucous sheath enclosed in a thin fibrous investment. The tendon is reflexed caudally, laterally, and inferiorly beneath the superior rectus to the lateral part of the bulb of the eye and is inserted onto the scleral surface behind the equator of the eyeballs. The insertion of the muscle lying between the superior rectus and lateral rectus. The primary action of the superior oblique muscle is intorsion, so to speak, internal rotation. The secondary action is a depression, primarily in the adducted position, and the tertiary action is abduction, lateral rotation. It is supplied by the lateral muscular branch of the ophthalmic artery. Inferior oblique muscle. It is also called obliquus oculi inferior. It is a thin, narrow muscle placed near the anterior margin of the floor of the orbit. The inferior oblique is an extraocular muscle and is attached to the maxillary bone and the posterior inferior lateral surface of the eye. The inferior oblique muscle is innervated by the inferior branch of the ocular motor nerve. Its actions are extorsion, elevation, and abduction of the eye. Overall, its origin is at orbital surface of the maxilla, lateral to the lacrimal groove. Its insertion is at laterally onto the eyeball, deep to the lateral rectus. Finally, we have another extraocular muscle, which is described earlier in the part 1, the levator palpebrae superioris muscle. This is the end of the whole part 3 lectures. Thank you for watching. Stay tuned.